Welcome to Real Birth Stories. No actors, no scripts, no sensationalism, just real birth stories from my years as a midwife. Every birth is different. Every birth has something to teach us. Every birth is unique. The more birth stories you hear, the more you'll become confident at recognizing those reassuring patterns of labor. I'm Kathy Frey, semi-retired senior midwife, maternity author, and founder of MotherWise prenatal education. Let's begin. So just a reminder, while I'm doing this, I'm referring to my actual clinical notes. So sometimes I need to sort of pause and read them as we go. So we're going to call this woman, give her a pseudonym name of Lucy. And Lucy was 28 years of age. She was a G2P1, so that's gravida 2 parity 1, meaning that this is her second pregnancy and she's had one birth before. And that was a normal vaginal birth that she had in her home country, which was in Southeast Asia. So she did speak English, but it wasn't, she didn't get to the point of needing a translator, but we had to move kind of slowly in the conversations. And but that particular baby was still living back in Southeast Asia, living with her parents, so the baby's grandparents. So this was her first baby with me, and in a whole different country with a whole different maternity system. Okay. Her previous birth was at 38 weeks. And she had an induction of labor for a prolonged rupture of membranes. And they really sort of got onto it fairly expediently, as she had the pregnancy-induced hypertension or high blood pressure from her pregnancy, which always has the risk of becoming preeclamptic toxemia. So they use syntocinon to induce her labor. It was a 16-hour, she said, labor. That seems, fairly drawn out. And she breast and bottle fed the baby for the first 6 weeks. So this time before the baby went to the grandparents, and this time she is really keen to have successful breastfeeding. And really, in my experience, look, practically 98% say of women can actually fully successfully breastfeed as long as they're given enough adequate support and education to know how to do it. There's this, misnomer that it should be all easy and natural. It's not. It is natural. It's not easy. And, I always say it takes a good 5 to 6 weeks for breastfeeding to successfully establish. So that's at the point where that woman looks super confident. She can kind of go into a cafe and just lift up her top and discreetly attach her baby, and it all looks really easy, and her nipples are no longer sore, and the milk supply and demand is all evened out. It takes a good 6 weeks easily for that to occur. And I think that so often women, when they do start breastfeeding, they get to, day 2 or 3, and they're already sort of emotionally committing breastfeeding hurry-curry, because they're going, oh my God, this is so hard, and my nipples are about to fall off, and everything's so difficult, and it's not working. Yeah, that's just normal. That's normal. She just needs the education and the support, and she'll get through it. Okay, and her baby was quite petite last time. It was on the 19th centile, which is within completely normal range, but it's sort of on the smaller side of normal. So after a baby's born, based on the woman's pre-pregnancy height, weight, in other words, her BMI, her ethnicity, and based on when the baby was born, like at what gestation, we calculate on a customized growth chart exactly what centile that baby was sitting at, and her baby was sitting at the 19th centile. So that means that basically 80% of babies are bigger than that baby. And that's fine. I mean, everything varies in nature, so we expect babies typically to weigh anything from about 2.5 kilos to 4.5 kilos. So yeah, they're going to vary. So she makes not big babies, basically. Healthy, normal size, but not big. Okay, so now we're getting on to her pregnancy, and in this particular pregnancy, she's got no medical histories of concern. There is just that little red flag that she did have pregnancy-induced hypertension in her previous pregnancy, and so obviously there's a lot of excitement because this is going to be the first baby that she's going to be raising as their own child. So what happened with her? Let's have a little look. So on the 3rd of the month, let's have a look. Sorry, on the 2nd of the month at 9 p.m, her waters ruptured. And let's just have a look at her gestation at that point. Okay, so she is 37 weeks and 6 days, and she's admitted 37 weeks and 5 days is when her waters ruptured in the evening, and then the next day at 7 weeks and 6 days she was admitted for prolonged rupture of membranes. Now, it is quite a well-discussed area as to just of obstetric medicine as to how long one should allow or encourage or, endorse a woman's membranes to be ruptured with a fully termed baby before starting to intervene. And there's habits that have been done within obstetric culture where within 24 hours, if she's not spontaneously going into established labor naturally, then we should be inducing. And then there's other modes of thought where we should give her at least 72 hours, at least 3 days, and just keep monitoring her temperature. And if there's any signs that she's having any kind of infection, then get her in. But otherwise, just let her carry on, because statistically, most babies will be born naturally at about 2 days after a prolonged rupture of membranes. So sometimes it's just a matter of just having a little bit more patience, especially with first babies. Because if we induce a labor of a first baby, that woman has significantly higher chances that may end up as an instrumental delivery of ventouse or forceps, or a C-section delivery, which is a surgical delivery, because chances are, if she's a primate, if this is her first labor, and she's being induced, she's probably going to need an epidural. And that's a whole other different topic, and epidurals substantially increase the risk factors in labours. So, however, with this lady, she was a multip, so this is her second or subsequent child. In this case, it's her second. And so at the end of the day, it's a woman's choice, and she was happy to be induced. And because she's a multip, when we induce multips, they do tend to progress on fairly well, fairly nicely. It's actually, I'd have to say, it's actually really quite rare that with multips that waters rupture and they don't go into spontaneous labor fairly soon. In fact, off the top of my head, I would say I'd be lucky if that would happen to me once a year. Like, it's kind of rare for multips, when their waters break, usually that's it. They are going into labor. All right, so let's continue this story with who we're going to call Lucy, and let's see how that all continued on. I'm just looking more detailed into my notes here. Now, it turned out that at 37 weeks and 3 days, we did a growth ultrasound scan on this woman because her baby was a little bit petite last time. Like, I mean, it was within normal range, but at the lower end of normal range. And so I decided that I think we'll just do a growth scan and just make sure everything's on track. And on top of that, when we have a look at her fundal height measurements at that point, let's just see. Yeah, so, okay, she was tracking a good sort of 3 to 4 centimeters below average. So that would be another reason why I've said, okay, let's do a growth scan and see what's going on with this baby. Just making sure that it's doing really well. And we actually had a growth scan at 25 weeks and 31 weeks and then 37 weeks and 3 days. So yeah, so that 37 weeks and 3 days showed that the baby had absolutely normal liqua, so that's normal level of waters. The Dopplers or the umbilical artery flows were excellent and fine. The BPB or the biparietal measurements were everything was good. Everything was good, except the estimated fetal weight did put that baby at, let's have a look. Yeah, it did have the baby as looking a little bit petite. Also, its abdominal circumference was a little bit smaller than its head circumference, which is another way that we can ascertain that the baby is a little bit more skinnier. So we do expect that the head circumference and the abdominal circumference are pretty similar. And so the baby was okay, definitely not in terrible trouble, but also a baby that we'd want to keep a little close eye on, basically. So I would have been doing another growth scan at some point, but her waters ruptured, so it was a good reason to get on with that labor. And let's have a look. And she had a great CTG, or the trace of the baby's heart was looking absolutely fine. And in fact, she was having a very mild contraction by the time she came in that next day. So her waters ruptured in the evening and she came in the next afternoon, and she was having a little mild contraction every 7 minutes. So the plan was to get her started with an induction and some antibiotics to just make sure prophylactically that uterus is not going to potentially have any kind of infection, because once the waters rupture, in theory that baby's now in a potentially non-sterile environment. So it was all just, everything was fine, everything's tickety-boo, we're just being proactive with everything. So at 4 o'clock I did a vaginal exam with her consent. We needed to sort of ascertain where she was at, and at that point her cervix was already 1 to 2 centimeters dilated, and it was stretchable to 4 to 5 centimeters, which is great. And the baby was stationed -1 to -2, which means that it was still a little way up in the pelvis, but not too far up. And also the baby's position was LOA, which is left occiput anterior, which is really perfect. It's like the most perfect position to be in going into labor. So that is absolutely wonderful. So we started an oxytocin drip, and myself as a self-employed on-call midwife, I then handed her over to the core or hospital rostered staff, because my job is to look after women when they're in established active labour, and she wasn't. So basically the plan would be that the core staff would be assisting to get her into labour, and as soon as she was in good strong labour, they'd call me, and then I would be there for the rest of the process. At 11:30 at night, she's been in there for a few hours now with the induction, and everything's looking tickety-goo. She's got some tightenings of contractions that are now every 5 minutes. Still a little irregular, but they are slowly increasing in strength, and everything's looking tickety-boo. At 1:30, so 2 hours later, she called the staff and said that, oh, my contractions are getting stronger now, they are more painful. And at 1:45 in the morning, the staff performed a vaginal exam with her consent. They found that her cervix was fully effaced, and she was 6 centimeters dilated, which is brilliant. And the baby's head was well applied to the cervix, so good bit of pressure there, and at -1, so she's just 1 centimeter above the ischial spines. And they called me, so yes, they called me at 1:45 in the morning, and so I obviously would have been in bed at that time. Well, sometimes I could be at another labour, to be honest. But yeah, they would have woke me out of bed, so I'll get my A into G and get ready and get up and get into the hospital ASAP. And okay, then at 10:01, so 5 minutes later, they report that she has got strong contractions lasting 60 seconds long, and she's having 4 in every 10 minutes. So boy, she is starting to rock on. Basically, it's sounding like she's already rapidly heading into a transition or advanced active labor. Okay. So then, at 2:05, so 5 minutes later, 2:05 in the morning, bearing in mind the staff have only phoned me at 20 minutes earlier, and I lived like a good half an hour from the hospital. Okay, so then let's have a little look. I arrived in at 2:30 in the morning. So I'm just looking at the notes here. Actually, 2:28 to be precise. So that wasn't too bad. They rang me at 1:45. Took me about 10 minutes to get my act together and in the car, and then to the hospital, parked in upstairs into the birthing suite. And I arrived there at 2:28 to find a baby was already born. So let's look back on what happened. So at 2:05, the woman reported rectal pressure plus, so a lot of pressure. So which is great. That means the head is very low, and meaning that she's getting a real irresistible urge to push. When women do get that irresistible urge to push, we always will be recommending that we do a very quick VE, a vaginal exam, just to make sure that the cervix is absolutely fully dilated, because if it is not and she starts pushing prematurely, we do risk her rupturing the cervix, which is a whole freaking nightmare of mess and bleeding and repair afterwards. So, it's better to get her just to breathe through and blow through those really strong contractions if she's not quite fully dilated. But let's have a look at that point. Okay, so at 2:05 they did another vaginal exam. She was stationed +2. Oh my goodness. Okay, +2. So she'd gone from -1, which means 1 centimeter above her ischial spines, to +2, which is 2 centimeters below the ischial spines of her pelvis. That baby's about to be born. When it's at that point, we're just about seeing head. And at 6 minutes past 2, her husband arrived. So they lived closer than I did. and at 2:08, they phoned me again, and just to let me know that she was fully dilated and pushing. And 3 minutes later, at 2:11, the baby was born. With immediate skin to skin, it had crying within the first minute, ABGARs of 9 and 10, fantastic. And because she'd had an induction, it meant that we did need to do a managed delivery of the placenta rather than doing a physiological birthing of the placenta. When we've been using syntocinon or syntocinon, or it would be syntocinon for an induction, it means that she does have a little bit of risk factor for hemorrhaging, and until that womb is empty and contracted, she has the risk of bleeding. So it can't be empty and contracted until that placenta is birthed. So the baby was born at 2:11, and the placenta was delivered at 2:15, and she had an estimated blood loss of 100 mils. So that's awesome. I mean, that's hardly anything. You know, anything up to 500 mils is regarded as normal. And yeah, so that's a tiny amount of blood loss. So a very great outcome. And her perineum was fully intact, which typically with second babies, they usually are. And then at 2:28, I arrived, and at 2:34, that baby commenced breastfeeding on the left breast with wonderful coordinated sucks. And, you know, so those babies that have those lovely, nice speedy births, they do well. So let's have a look. In total, let me have a look here. I'll just put it on pause. Okay, so we noted down that her labor was established successfully into active labor at 1:20 a.m. and she had the baby at 2:11 a.m. Not bad, eh? 50-minute labor. That's what can happen with second babies when you have given birth spontaneously vaginally before. Awesome outcome, right? Okay, so I'm going to pause again and let's have a look at the postnatal notes. Right, so I did 5 home visits with this woman. I did also visit her. So after she had the baby, she then in the hospital, she then transferred to a local birth center, which is about an hour from the hospital. But I would get a lot of my women to go there because it's just the most fantastic birth center. So a lot of my women would birth at their birth center, and even more of my women would have their postnatal stay there. It was, yeah, so she could not have birthed there because she was being induced, so that needed to be at the hospital. So I visited her, let's have a look, a couple of times at the birth center, and so then she got home, and let's have a look. So this baby was born on the 4th, and I visited her. She discharged home on the 7th. So that was a lovely little stay that she had. And so on the 8th, I did a first home visit. Now her breasts are starting, this is all my notes, her breasts starting to soften. So that means she would have had engorgement sort of the day before. And I also reminded the husband to go and get some Hypercal for her sore nipples. Hypercal is one of my favorite products to use on sore nipples, sore perineums, Caesar scars, basically anything to do with your skin. It's a homeopathic product, and you want to get it in a cream or a lotion or a gel. And it's Hypercal is a mixture of hypericum, which is a natural antiseptic, and calendula, which is a skin healing promoter. Okay, so her breasts were starting to soften, but her nipples were sore. So I said to the husband, go get her some hypercal. Her lochia, or her vaginal discharge, was light serosa. So that means that it's great. You know, that's just really normal. Excellent. It's serosa, so it starts off being rubra, which is bright red. Serosa becomes pink, and then later on we have alba, which is white. So she's got a light level of serosa, so that's excellent. Her perineum was a little bit sore, but it was improving every day, and that hypercal would really be helpful for that as well. In general, in great supports, questioning what her level of support is. The husband I got here doing the best he can. Just encouraging her to take it slowly and easy, because I don't know that she had a lot of family around. So then I return again on day 9. Her breasts are improving. The right nipple is still a little sore, but getting better every day. Her lochia is still, her discharge is still light serosa. Brilliant. Her perineum has improved a lot. Yay, hypercal. In general, good spirits and reasonable support going on. So that's great. Then her breasts, all good, no problems. So now we're at day 16. Her breasts are all good, no problems. The lochia is now scant alba. So we've progressed onto the whitish creamish discharge, which can go on for, that usually starts around about day 10 and can go on for 4 to 6 weeks. You just need a panty liner really at that point generally. Perineum feeling much better. In general, what has she got? Okay, she's getting a little itchy in her vagina. She's got vaginal itching. I think she's got a little bit of thrush going on. Awesome. Every woman needs that in the postnatal period. Yay. So I prescribed her some clotrimazole cream to help with that. Then back again on day 23. Everything's all fine. No concerns with her breasts at all. Lochia is scant. Perineum is all fine. Thrush completely resolved. General and good. All good. Zero concerns. Her family have now arrived from Southeast Asia, and they'll be there for 2 weeks. So that's neat. No, it's nice to have your mum there. And then on day 30, I did another visit. Oh, okay. So it looks like maybe her left breast could have a blocked duct. And so, yeah, the best solution for that is some antibiotics, and also just for her to dominantly feed on that side. She just needs to feed and feed and feed and feed and empty and empty and empty and empty that breast. I prescribed her some Fluclox antibiotic, just a week of it, to 2 doses. I gave her 2 doses from the bag, from my bag that I had with me. So I gave her a dose immediately and a follow-up dose, and then I gave her a prescription for 6 hourly Fluclox to just make sure that that blocked duct didn't turn into something more serious, which is like mastitis, or it can get horrible after that. Okay, and her lochia had ceased. Her perineum felt absolutely fine, and she was discharged in excellent spirits. So isn't that cool? And let's just have a little look at the baby. So, yeah, 50-minute labor, we call that precipitous, is what that baby experienced after a 29-hour prolonged rupture of membrane with prophylactic antibiotics. The weight of the baby was pretty little. It was on the 2nd centile on a customized growth chart. So yeah, that was a little baby. But it did really well, coordinated productive suckles straight away. So it was confirmed as not an IUGR baby, meaning it was not a growth restricted baby. It was purely a symmetrical what we would call SGA, a just small for gestational age baby. All right. So we would question, is it just familial, meaning is it just her family makes small babies? It's just naturally, genetically a petite baby. And I mean, a lot of Southeast babies are petite anyway, but it just might be normal for that baby, even though we do check it on a customized growth chart. Okay, so let's have a look. At day 9, with that home visit, 3 hourly feeds on demand, making 10 wet nappies a day. Awesome. Look, you never have to worry about how often a baby, how much a baby is receiving in milk if it's making 10 wet nappies. There's no question. 8 to 10 wet nappies a day. Thriving baby on breast milk. Let's have a look. Had a little bit of nappy rash, so we dealt with that. Day 16 was feeding 2 to 3 hourly during the day, 3 to 3.5 hourly overnight, including the typical evening cluster feed. Again, at least 10 wet nappies every 24 hours. It had put on a whopping 280 grams in 7 days. Woo, so good. Day 23, 3 hourly day feeding, 4 hourly overnight, evening cluster feeds, 12 wet nappies every 24 hours, put on another 260 grams in a week. Wow. Okay, by day 30, 2 to 3 hourly day feeds, 3.5 hourly overnight, vigorous, responsive, alert, loads and loads of wet nappies, loads of soft stools. Oh, that's poo. 380 grams in 7 days. Oh my God. This is just a huge breastfeeding success story. And I got to say, most of my women would be like that. It's all about support and education. So when we bear in mind that this baby was born at 2370 grams, and by day 30, it's 3480 grams. And I always say, until that baby is over 5 kilos and over 5 weeks, so it's both of them, over 5 kilos and over 5 weeks, you should not be taking them anywhere. They just need to stay home. They're just not robust enough under that. And the best thing to do is that first 100 days, or at least absolutely the first 40 days at home. And as much as possible of the first 100 days at home. And we want them to put on a good kilo in that first month. It's just fantastic. Well thriving baby. So there we go. Look, that's the end of that story. And so no actors, no scripts, no sensationalism, just extraordinary birth stories is what we're all about. And for more information, please go to my MotherWise masterclasses, www.motherwise.com. Oh, sorry, .app, www.motherwise.app, app, and there you can sign up to learn way more about everything you could need to know as a pregnant woman to get you through your entire maternity journey, right through to the end of the postpartum period. Online education, it's honestly, hand on heart, the best online course I've ever seen. And for lots more information about me, you can go to kathyfrey.com. Have a great rest of your day, everybody. Bye.